Welcome back to another episode of the Best You podcast. Today we're diving deep into the topic that affects so many of us, and that's joint pain. I'm joined by Dr. David Karli, a renowned leader in the field of regenerative medicine, who's going to share his expert insights on how to prevent, manage, and even reverse joint pain. In this episode, you're going to learn what causes joint pain, how to know when to push through pain or stop working out if you're feeling pain, and some incredible regenerative therapies like PRP, which is Platelet Rich Plasma, and BMC, which is bone marrow concentrate. And these things can heal even more serious joint conditions. By the end of this episode, you're going to have the knowledge and the strategies to both prevent joint pain and explore advanced treatments that can possibly bring you long-term relief. Before we dive in, don't forget to hit the follow button on the Apple Podcast app and on Spotify. And if you're watching on YouTube, make sure you hit the like and subscribe button down below. All right, what's up, everybody, and welcome back to the Best You podcast. Today, I am super excited to be joined by the one and only Dr. David Karli. I am really excited because there's a lot of people who are listening to this podcast, or everybody who's listening to this podcast is pretty fitness focused. And a lot of people, one of the things that might hold them back from training is joint pain and just pain overall in their body. And so I'm really excited to dive into a lot of the stuff, like I said to you before, that I didn't really necessarily have a whole lot of education on myself. Your profession, essentially, you guys focus on cellular therapies, treatments that use some of your own tissue, your own blood, cells from your own bone marrow, or cells from fat to treat different orthopedic problems. And these things are collected, concentrated, and reimplanted at the site of injury or disease. And we're going to kind of dive into that stuff. But the way I kind of want to start today is just kind of like going to the root of the problem. Like, what causes orthopedic issues? Like, what causes joint inflammation? What causes shoulder pain? What causes knee pain? Is it like just over time, excessive force applied to that area? Like, what causes orthopedic issues?
Yeah, well, first, Nick, thanks for having me on very much. It's an honor to be here and speak with you. Congratulations on the podcast. That's fantastic, and great to allow a platform for me to get my message out. Every one of those things you just pointed out, we could do a full podcast on. But to answer your more specific question, and it's a really important one, what causes the orthopedic system to fail with time, with aging? The primary driver isn't activity. That's what you would think is the case, what you just mentioned. The primary driver is actually a flaw in design, believe it or not. Almost all the tissues that we spend the huge majority of our time are what we call avascular tissues. What avascular means is there's no direct blood supply to these tissues. Cartilage, discs in your spine, meniscus, rotator cuff, Achilles tendon, etc., on and on and on. Almost all those tissues have a lousy blood supply. With a lousy blood supply, they don't have much intrinsic capacity to heal, to fix themselves. So then if you combine that model with what you just said, cumulative microtrauma over years and years and years of leading an active life, which we want, right? That adds up. It's cumulative. So it's not necessarily someone rips their rotator cuff. That happens. But more commonly, it's little by little by little scar tissue and micro tears and wear and tear form. And it creates a disease tissue state that leads to what? Pain. Okay. So, you know, we talk about longevity and functional life and active lifespan and all these important issues that are so hot right now. I believe the biggest limiting factor preventing people from living a long functional life is orthopedic. It's not the brain, it's not the heart, it's not the lungs, it's not the liver. Because if we can drive lifespan longer, but the orthopedic system is going to continue to deteriorate, well, you'll live longer with a crappy quality of life. So it raises the important issue. If you look at the lifespan curve, it continues to increase. We took a little blip with COVID, but over hundreds of years, it continues to increase. If people are going to continue to live longer and we don't have solutions for these orthopedic tissue problems, we've got a mismatch. Longer life, wheelchair, right? That's no good. I think we both agree functional lifespan is the goal, not just lifespan. And I think the biggest problem we face is orthopedic.
Yeah, there's no doubt about it. I mean, it doesn't matter how much motivation or how badly you might want to train. If you're in pain, you can't be able to do certain things. You are not gonna be able to move. And if you can't move, whether or not it's high intensity training or weightlifting, if you can't move, your health is not going to be improving. It's going to be declining. So let's talk again and kind of like the prevention side of things before maybe we dive into some of the cures or remedies, if you will. What are some of the things that we can do if these tissues don't have direct blood supply, so they don't have an intrinsic capacity to heal? What can we do to ensure those are stronger and more resistant to injury or inflammation?
I think it's a twofold answer to that question. The first one is use it or lose it still applies even in the face of deterioration and pain. We want to exercise an arthritic joint. We want to exercise a damaged tendon. Now, pain becomes the limiting factor. So there's symptoms and there's function. There's two pieces to this, right? So to apply a scientific principle, bodies in motion stay in motion, not the case here, right? Painful bodies don't stay in motion, right? We have to force ourselves to continue to train when intuitively we're hardwired to think that pain equals damage. Pain doesn't necessarily equal more damage. So when you have a painful arthritic knee and it's mild to moderate, the first thing your brain is telling you to do is shut that joint down. Well, what happens? We get weaker, we get unstable, and it contributes to the process. It's a slippery slope. So the first thing we can do to maintain healthy tissues in light of aging or in light of degenerative processes that are bound to occur in everyone is to keep the body moving. If we can just keep the body moving, symptoms aside for a moment, if we can just keep the body moving, that's number one. Exercise is still the greatest drug in the world. Even stem cells, right, aren't as good as that. Now, where we come in, and the second piece to that question is, if symptoms become the limiting factor to a body moving, that's our opportunity to intervene to try to get control of symptoms. Most degenerative tissues are still functional in nature. They're not going to fall apart. They're not going to break. They're limited by pain. They're limited by symptoms. So most people have a symptom problem, not a structural one necessarily. If it's a structural problem, that often requires surgeries and things of that nature. Sometimes yes, sometimes no. But it's a symptom problem for most people. So if we can keep people moving and those people that stop moving due to symptoms manage that effectively, now you've got the single best way to battle this process, which is keep the body in motion. You got to control symptoms along the way or you're going to chase your tail, so to speak, right?
Yeah, for sure. And I feel like my next thought is, you said that pain doesn't necessarily mean that there's damage. And so that doesn't necessarily mean that you shouldn't be doing things that maybe provide a little pain. Let's say, for example, I know so many people that say, I have knee pain, so I can't do like a squat, or I don't want to do lower body exercises, when it's like, I think, depending on the person, obviously, that's maybe exactly what you need to be doing, is like doing some lower body exercises. So when do you know when pain should actually cause you to not move and you need to go get it checked out, versus when pain is like, no, we actually need to be moving that area of the body?
It's a great question and a hard one to answer, because the answer is it depends, right? Yeah. So as a general rule, 9 or 10 out of 10 pain probably should warrant an evaluation. You know what I mean? But right. Let me use myself as an example. I'm 53 and I still like to train, and I'm going to do it as long as the body will let me train hard and maintain muscle mass and have a muscular look. I like that. I enjoy that. But I also induce, by choice, a low-level state of chronic pain. I'm sore at 53, right? If I train hard, it's going to be sore, and more so than when I was 25. And that's okay. The upside outweighs the downside of doing so. But in that light, my mindset is, I know I'm going to hurt, especially if I want to train this way. And I don't just train to feel good. I train to perform well and to maintain muscle mass and do the things. I like to try to be the example in that regard. But that's a situation where my brain is telling my knees during those squats, you're hurting, knock it off. But that's the absolute wrong thing to do. I've worked with a lot of pro athletes over the years, trying to do workarounds of injuries and maintain their playing careers and so forth. And there are a lot of situations because the body is hardwired to do workarounds. If your back's hurting, figure out how to play without using your back. Well, guess what happens? More and more weakness sets in, and then you're set up for worse injury and worse problem and chronicity and all those things. So you can be an elite level athlete and still have a functional part of you that's extremely weak and unstable. So the answer is, when in doubt, go get checked out. Okay. Ask someone like me, hey, is this okay or not? If you're not sure. But by and large, most of the time, continuing to move, continuing to exercise a tissue within reason is going to be the answer to most of those questions.
Mm-hmm. And is it, and some of the time is, if someone like you was telling me that pain is okay, keep doing what you're doing, but is it like, if it doesn't get better, then come back and see me, or stop? Or like, should things improve? Like if I have knee pain and then continue to move and like do smart sound training with my lower body, should things improve because of what I'm doing?
Not always. So another great point, and we tell patients this. Let's use physical therapy as an example here. Okay. I tell patients who go to physical therapy to try to manage a problem, one of two things is going to happen. You're going to get stronger and feel better, or you're going to get stronger and feel the same. Those are both reasonable outcomes, just trying to rehab a problem. Let's just say it's a rotator cuff problem. Okay. Now, if you go to physical therapy and you work really hard and you feel better, you don't need me. Great, wonderful, fantastic. Best case scenario. But if you go to PT and you actually put forth a good effort and the PT knows what they're doing and your function improves, but your symptoms do not, again, opportunity for me to try to manage those symptoms more effectively and see if we can keep that moving forward from a rehab standpoint, but also intervene from a quality of life standpoint. Because to answer your question, it's hard to continue to do this at a reasonable level when you hurt. It's really hard. It wears you down. And then, it can affect sleep, and it can affect mood, and it can affect so many different things. It's a constellation of symptoms. But by and large, we probably should push more in most degenerative situations, and we shut it down too much.
Gotcha. Okay. Good to know. I think probably last question on the like prevention side of things is, what role does I know you're, like you said, you're big into resistance training and training hard. What role does building up your muscles play in the pushing off any kind of injury, or pushing off any kind of like arthritis, or pushing off any kind of like inflammation? What role does building up your muscles and resistance training play in that?
Well, it's never, old school meatheads like me have been doing this for years, but now you're hearing muscle is the longevity organ. And, we've kind of known that for a long time, but it's great to see that that's coming to light and becoming, more prominent. Wonderful. Great. The body responds to load. It's designed to do so. If you don't load it, what happens? If you put your arm in a cast over a number of weeks, your arm is going to atrophy because you're not moving it. Now compound that with load, with resistance. Even as we age, our bodies and our muscles in particular still respond to load. What happens, the limiting factor as we age isn't muscle. Actually, I'll get back to that. It is to some degree, but it's not the primary limiting factor. It's joint. It's joint pain and ligamentous pain, or osteoporosis, or whatever might be the case. Muscle still responds to load. Now, what gets interesting is this concept of sarcopenia, design muscle loss as we age, and some people believe that's a function of hormones. Some people believe it's just an intrinsic built-in design to our cells. I know that if we correct hormones in people who are low, who are losing muscle mass and experiencing symptoms of lower hormone states, guess what happens? If they train, their muscles respond. If they train without fixing that problem, the muscles don't respond. So again, it's a psychological feedback loop. Let's use a guy with a low testosterone situation, whether he's symptomatic or not. Well, his belly's getting bigger and he's still training, but he doesn't have the gas in the gym like he used to. But most importantly, in his brain, his muscles aren't responding anymore to that because the match isn't lit. So you correct that situation. And I know hormones, for some ungodly reason, are still a controversial topic. It's ridiculous in aging folks who are appropriate for that type of therapy. However, imagine that guy who's working his tail off and doing everything he should be doing, but his body is not responding. Eventually he loses interest because he's just not getting results. There's no positive reinforcement. So in those situations, again, opportunity to intervene to help that person's quality of life, but equally as important, maintain their muscle mass, which is a driver of so many disease reduction scenarios. Okay, because when we lose muscle mass and sarcopenia sets in and we put on belly fat and we lose conditioning, guess what goes up? All-cause mortality, the risk of dying from anything. Exercise is probably the number one thing you can do to reduce your all-cause mortality, but the body has to respond to that exercise.
Yeah, no doubt. Just out of curiosity, you said you're 53 years old. What is your usually your current maybe like weekly training look like? What does your routine look like right now?
I'm a gym rat, but I do it because I love it. I enjoy it, and it definitely gets harder. And I optimize my hormones. I started, I think, around age 45, and it helps. It helps, but I still hurt, and it's still hard, and I'm still 53. So even though we can light the match, so to speak, to keep the the motivation and the drive and the muscle response to the stimulus there, the discomfort piece is still a problem, and it's hard to manage. Some days are better than others, but it becomes a motivational thing. So I like to resistance train. It's my preference, kind of old school, traditional, nothing fancy. There's no magic bullet from my perspective. You have to do the work. Body responds to load, you need to load it. If you want to get stronger or induce hypertrophy in your muscles, you need to progressively load it, right? Progressive resistance principles. Now, that said, it's not everybody's thing. I get it. But on some level, we want every single person forcing resistance across their muscles and their tendons and their tissues. By the way, tendons respond to load as well as ligaments, just the same as muscle. Now, not to the degree of hypertrophy of seeing a change in the body, but those tissues also respond to load, and they need load to maximize functionality. So I'm a gym guy. I like to go and resistance train, and I can't say that I love. You won't like this one. I can't say that I love cardiovascular activity. It's not my favorite thing to do, but I recognize the importance, right? I recognize the importance. What's my primary motivator to train? Well, accomplishment in the gym. I just like the challenge of the gym every day, but I like to look a certain way. I like to look muscular. It makes me feel good. It makes me, on some level confident. I just like that. So it's easy for me to do. It's fun. That's my hobby. Now, someone who doesn't like that stuff, they got to kind of force that. But it's really critical that we maintain an element of resistance training. And there's a lot of ways to do that. I'm a gym guy. I like to go lift weights. There are certainly other ways. But one way or another, we got to put force through the tissues to maintain them over time.
Yeah, no doubt about it. I love it. I love it. Well, I'm excited to dive into some of the work that you guys do in your clinic. And so I want to start off with PRP, Platelet Rich Plasma. You do a really good job of just explaining very simply what this is. So let's just start off simple. What is platelet rich plasma?
Platelet rich plasma is effectively taking platelets from your blood, concentrating them, and putting them where they can't get to. Now, why do that? Platelets coordinate healing under normal circumstances. You cut your skin, what happens? A scab forms. Well, what causes that scab to form and crust up? Platelets. Platelets also release their contents to recruit other cells to stimulate and induce the healing process. So they're a key driver in healing physiologically, generally. So what's a logical way then to approach avascular tissues, which we talked about earlier? Well, if the platelets and or the cells can't get to them, let's go get them and let's put them there, i.e. let's give that tissue a temporary capacity to heal if it doesn't have an intrinsic capacity of its own. That's the premise behind cell therapies. It's so simple, but the process that's induced is incredibly complicated. So simple premise, complicated process physiologically. But that's what PRP is. It's taking healing platelets, tissues from our blood, and putting it or parking it into an area that it can't get to, or to help facilitate a faster or more complete healing in a tissue that does have a blood supply, like a muscle injury or a muscle pull or a cuff injury or something like that. So it's not just avascular tissues. Or if you look at the aesthetic applications or hair or sexual dysfunction or some of the other applications where PRP is being applied, this is a tissue game, maintaining healthy tissues. So it's kind of tissue augmentation or tissue rejuvenation, if you will. Okay. If tissues aren't quite what they used to be because we're getting a little older or we beat ourselves up by leading super functional, crazy active lifestyles, let's try to improve tissue integrity. And if we can, guess what goes down? Pain. And guess what goes up? Function. So that's really what PRP is and what it's designed to try to improve and help.
And so is that actually Does that happen same day? Like, are you able to take blood out, like you put it in a centrifuge and then you put it in you inject it somewhere else? Is that like same day, or is it like you got to draw blood and then a week later come back and have it injected somewhere else?
No, so we're an FDA regulated process, right? So the biotech company that I developed in 2010 to produce these, and we can talk about the unique nature of that, and then the clinician implantation of it is all regulated by something called the Code of Federal Regulations, or CFR. So there are rules that we have to follow that are designed to keep people safe. Now, these are really low risk things to do. These are not dangerous. You can't reject your own platelets or your own cells, right? And that's why we focus on what's called autologous, or using your own. So we follow those rules, which state that you can take them out and concentrate them. You can't change them. You can't manipulate them. You can't genetically engineer them. You can't culture them and then immediately put them back into the body. So they're fresh, they're alive, okay? So they don't sit overnight, or they don't incubate, or they don't do anything. They come out, they concentrate, go back in a PRP type situation, okay? Yeah. Now, what's unique about our approach and my research over the past 15 years is the field was doing this, and trends in the research and literature showed that a lot of people were getting better, which is wonderful. But there was no standardization from what we call a cellular dose perspective. They weren't measuring the number of platelets, the number of cells, the number of stem cells, the number of progenitor cells. No one was measuring. They were just it was horseshoes and hand grenades, right? Let's just kind of get close and just get some platelets in there and let nature take over and drive and hope that things get better. And that's great. That got us to a certain point in the early days, but I said, that's not sustainable. We need to think of this more like a pharma model. There's a dose and a response, right? These things don't act randomly. They're not entropic. There's order to what happens when you put a dose of platelets in a rotator cuff tear, for example. So what we've done is we figured out how to measure all of the billions of platelets and cells and progenitor cells that are in these preparations before they're implanted. And then we track those measurements in parallel with patient-reported outcomes, how they're doing over time. So we do a pre-treatment survey, and then over the course of 12 to 18 months, continue to track them. And then we look and say, these patients did best. What was it about their dose or the parameters of their biologic? Here were some failures. Can we see a common thread? And we did that, and we developed this large database that allowed us to start to think about customization. I don't treat you the same as a 75-year-old diabetic smoker. I don't treat a cartilage problem the same as a tendon. A one-size-fits-all solution doesn't apply to everyone. So we wanted to continue to drive towards precision medicine, or treating you the best you can be treated and that problem on that day. Yeah. Now what we're doing is taking it a level further to identify subtypes of stem cells, for example, and even at the genetic level, start to look at how someone's genome or epigenome actually influences the behavior of their stem cells or their platelets as we put them into different clinical scenarios. So it gets super, super technical scientifically.
Yeah. Wow. That's fascinating. So probably along maybe similar lines, have you guys found that somebody's blood has to be a certain level of like healthy, if you will, or a certain blood type works better with certain people? Like if somebody comes in and their like blood work is not very good, is that blood not going to be as useful at regeneration and healing, or does that matter? Talk to me about that.
Intuitively, it makes sense, but it hasn't panned out in terms of what the data is showing. And I'll using an arthritis model, we don't treat 30-year-olds with arthritis. They don't get arthritis. So all of the data for arthritis, which is a lot of what we use to model, is in 16, 70, and 80-year-olds. 80-year-olds, right? They don't have any stem cells. They don't have good blood. Not the case based on the fact that they are continuing to respond to these types of therapies. So this whole notion that as we age, we don't have good blood, or as we get older, we don't have progenitor cells or stem cells anymore, they do decline, but we're able to overcome that by concentrating further. So for example, in someone who's a little older, we might push the dose up a little higher to overcome for a natural reduction in the therapeutic capacity of those cells. That's just an example. And these are the things we're trying to tease out. What is the optimal dose, thinking prospectively, that's going to give you the best chance for a successful return on your investment? That's the ultimate answer to your question. So imagine me counseling you, Nick, in two ways. One way is this, which has been the way it's been done 99% of the time across the world. Well, Nick, we have lots of papers on this, and we can take your ACL tear and we can put some of this PRP in there, and there seems to be like a 70% chance you're going to get better, but we're not so sure. So let's just give it a shot and we'll see how it goes. That's option one. Versus, Nick, we've treated 873 people with your problem, and we see that when we make this PRP, you have an 82.6% chance of at least 50% return, 50% relief of your pain lasting at least 3 years. You see the difference between the two?
Yeah.
You can make a better educated and informed decision with the knowledge of the data of a likelihood of success, predictive value, predictive modeling. And that's what we were lacking. So our company and our clinic is really a model that's trying to drive that platform forward to say, it's not good enough to not know. What doctors don't know what dose you're giving when it comes to a drug? Of course, we know. The drug wouldn't even be on the market if we didn't know the drug. But that's what was happening in the cell therapy world, is we were just winging it. And that's not acceptable, in my opinion, especially for cash fee-for-service therapies that are expensive. So if we're going to, if these are going to be expensive market-driven procedures, then we're obligated to give that patient consumer odds on the likelihood for a return on their investment. And we couldn't do that before. Now we can. So it helps me to educate much more effectively whether or not patients should do this. I tell every single patient, almost no one needs a stem cell injection. This isn't cancer we're treating. You're not going to die. This is an option, and we look at the pros and cons of all your options and weigh this one compared to the other ones. Now, so often patients already know what they want when they come to see me, but we still go through that exercise because it's really important. And this is a huge deficiency in the field. In my opinion, it's malpractice to throw some PRP in there and not know what the dose is, because we know that low dose PRPs don't work very well, and high dose PRPs work a lot better. So we want to make sure we're up there every single time.
Yeah. So yeah, for sure. So kind of a two-part follow-up question on that. What are the specific types of like arthritis? Like, what are the specific types of things that you guys use PRP for? That, and are there different kinds, like knee arthritis or like shoulder pain or elbow pain? Are there certain areas of the body that you have seen, for whatever reason, this works really well in people's knees, for whatever reason, this works really well for this condition in the elbow? Like, talk to me about what kind of conditions, and then if there are higher degrees of success in varying conditions.
Yeah. Well, there's two primary products we should talk about. We talked about PRP, and let's go through the second one first, and then I'll answer that question. The second product is something we call bone marrow concentrate. So it's a PRP because it's blood-based, but we get the blood from the bone marrow cavity. And that sounds scary, but it's really a simple procedure to access the blood. It's a fancy blood draw, basically. I tell people, if you can handle the dentist, you can handle this. It's not a huge deal, okay? And we keep you comfortable when you do it. So we get the blood from the bone marrow cavity, and in that blood are what we call progenitor cells. Stem cell is kind of a tricky word because it's so broad. Progenitor cells are cells that are stem-like. They're similar to stem cells, and they can make new tissue. But more importantly, they control and coordinate the healing process similar to platelets, but more powerfully. Okay, that's a simple way of thinking about it. And again, it's very complex science. So BMC, or bone marrow concentrate, is a PRP plus some of these high doses, I should say, of these progenitor cells. PRP, just the platelets. BMC, stem cells or progenitor cells, if you will, and platelets. Okay, I hope that's clear. It's a bit complex in terms of the nomenclature. PRP is used for common itises or common orthopedic problems, bursitis, tendonitis, lower level tendon injuries and tears, partial thickness tears, things like that. Okay. And the data on them is very strong. And as long as they're dosed accordingly and correctly, they work really well. Now, sometimes depending on the chronicity, how long someone's had a problem, it can be more than one PRP that's necessary. If we get to it early, sometimes one is enough. If they've had it for 10 years, sometimes we got to hit it a couple of times. But for bread and butter orthopedic conditions, PRP works very well. And that's plenty of data to prove that and support that. For arthritic conditions or anything in the joint, what we have seen is PRP works, but not long enough. It doesn't hold, and you have to redo them. So what we've been studying over the last 10 years is adding the progenitors or stem-like cells and the PRP together. And what we're seeing is a much longer duration of effect. So when we do a progenitor or a stem cell treatment, my intent is that that patient gets years, plural, of relief from a single application. That's what we're after. Now, we don't get that every single time. I wish, but we don't get it every single time. But that's what our goal is. So they're a little bit different, and the way we use them is a little bit different. More severe problems that need more anabolic stimulation to help, they're more of a cell therapy, not just PRP. Bread and butteritis is, I've had tennis elbow for 6 months. It's killing me. I can't get past it. I tried PT. I tried anti-inflammatories. I'm not better. PRP. And the data is really strong on that. So that's how we kind of gauge it from a simplistic way of thinking.
Gotcha. So you basically probably, when getting to know the potential patient or consumer, you ask them about the severity of the pain, the duration of their pain, and then you kind of make an assessment, obviously based off of your conversation with them and what you guys know with the science, and you make a decision to go PRP or BMC, depending on which one you feel like is appropriate.
Sure. I mean, it's a full comprehensive evaluation, including imaging. I mean, we don't like to do these therapies without imaging. In fact, it's not a good idea because you have to make an educated guess. And when people are spending their hard-earned money on a therapy like this, you don't want to make an educated guess. If you guess wrong, they're not better, and we wasted money. So it is a comprehensive evaluation that's necessary to be as specific as possible, to set those odds and expectations as closely as possible, but then also to know what biologic to make and where to put it. These are guided procedures. So like with a steroid shot, you just got to kind of get it in the area. These go into the injury. So if it's a torn tendon, the PRP or the cell therapy goes in the tear. It goes in the joint, okay? So there's a precision of the delivery of the biologic that's as important as the makeup of the biologic and the quality controls of the biologic itself. Both have to be right to get the maximal outcomes. So we go through that process. And again, there's a very specific series of things that go into it. People come here, and I always say this, it's easy to practice this medicine poorly. It's not hard. You get a little machine that makes you PRP, and you put some blood in there, it spins out, and you squirt it in the joint, and some people get better, and that's wonderful. When people come to our clinic, they say, I had no idea all that was involved. They come in and they do surveys, and they meet, and we go through this long, lengthy process and consent and marking, and then the blood is drawn, and then we go through all of their cell counts with them. And then, they're here sometimes for a couple of hours for what they thought was, I'm just going to go get a little injection. So to do it really well is meticulous. Right. For sure. And that's the difference between decent and great outcomes from what we've seen.
I love it. I love it. Well, the way I want to, last kind of topic I want to cover, and it could be covered for hours and hours, I'm sure, but I'm curious, you mentioned these avascular tissues, meaning these tissues that don't have direct blood supply. Certain people get arthritis at a much younger age and are maybe more genetically prone or maybe not. I don't know. So talk to me about, are these avascular tissues, like how genetically dependable is their ability to be restored by yourself versus how much is that lifestyle? I think that's right. I think that's the question I want. Like, how much genetic is it for them to be able to heal themselves versus lifestyle?
Really good question, Nick. And I don't have a perfect answer to that one yet, although we are literally applying for an NIH grant at the moment, which is going to study that very thing. How do genetics influence not only a disease process, but our ability to intervene? That's an important one that we need to answer. We do know that arthritis, for example, does have a familial component. It tends to run in families. And we ask that question, do you have first degree relatives who've had, premature knee arthritis in someone who's coming in a little young? Now, if they were a football player and tore their ACL twice and that's a traumatic process, right? But let's say the course of their life was relatively atypical and they're coming in at age 38 with a grade 2 or 3 knee OA. Okay, that's not normal. What's going on here? And then we dig into that process. It would seem logical that genetics would influence it, okay? How it influences, and more importantly, how we can intervene to overcome that are unclear. We're going to be one of the first people to look at that from a stem cell function perspective. We're very excited about that. God willing, we're able to get the grant and begin that work. And that's work between Europe and here, and the University of Miami. Actually, we're collaborating on that project. So hopefully that starts in January. But I think it's an important question that we need to answer. And it's kind of the way med tech is going. Increasingly, as technology has allowed us to dig into the genome, for example, in a cost-effective way, in a time-effective way, it starts to become a variable for study. Now it's insanely complex. And I don't think we could do this work if it weren't for the progression of machine learning and algorithmic learning, because the models and the data sets are so unbelievably complicated. There's no way a traditional group of statisticians would be able to weed through that, because you have millions and billions of variables, and it's A plus B, A plus B plus C, A plus B plus D, D plus E plus F, F plus X plus, you see how it just gets insanely complex, and you've got to go through that process, and you need the analytical data vehicles that can scour that data and start to pull out inferences. Well, this plus this created a trend. Let's take a look at that more carefully. So the positive influencers and the negative influencers can be teased out of this ridiculously complicated set of data. I mean, we have 3 billion base pairs in one human genome, right? The study is going to study 200 patients with NeoA and their cell therapy applications and try to put all of this to gauge cause and effect relationships. So to my knowledge, that's the first time anyone's looked at it in that capacity. So I think that's the direction we'll go to improve the precision, right? The precision medicine modeling that will continue to allow us to advance how effective we are, first in controlling a disease process, but ultimately what we all want, to reverse it. Yeah. We are not there today. Regenerative medicine doesn't reverse disease. It doesn't reverse arthritis. I wish it did. I probably would be retired, though, if I could answer that question, not be talking to you on this podcast. But that's where everyone wants to go. But it's kind of a crawl, walk, run mentality. We don't want to crawl for very long, though, because people want these solutions. And that takes a lot of resources. That's why we're getting more into the grant game, because, we're talking about, if you look at, I always like to use SpaceX as an example. They caught a rocket the other day in midair. The only way that happens is if the leadership and the team of people combine with the resources to do it come together. If you look at cancer solutions and you look at solutions to a problem like arthritis, if those three things, leadership, resources, and the right people, are working in a coordinated fashion, then you're going to see solutions. If it's fragmented, like it's made, well, this university is working on this and that university is working on that, and they meet once a year at meetings and kind of talk about it, but it's protected with IP, you see how inefficient that process is. So I think the space thing has been a great example of how private industry commercialized the right way can overtake a governmental agency in terms of their ability to move forward. And we saw that as a great example, and credit to Elon Musk for his outstanding work and drive to and competency to be able to make that happen. I think we need to take a similar approach in biotech, because we have the technology now to make those leaps, but it's going to take a very coordinated effort, but it's also going to take a lot of resources. This is not cheap research. Yeah. I can't do a study like this for $500,000. You see biotech companies raising Series A, B, C of hundreds of millions of dollars at a time, and we have to deliver on that. So it's a challenge, but I think it's one that, because the technology and importantly the data analytics have gotten to the point where we're able to actually address these questions in an effective manner prospectively, the resources have got to come, and the leadership has got to come, and the coordination of a common goal and the execution on that common goal has to move forward instead of the traditional scientific medicine method, which does work, but it's too slow. You want solutions today, not for your grandkids. That's nice for your grandkids, but you want them today. And the capacity is there if we can get our act together.
Yeah, for sure. Well, awesome. Well, good luck on getting that grant. That's awesome. This has been awesome today, David. Really have enjoyed. I feel like I've learned a ton, and I feel like everybody else has probably a lot more insight into the importance of some of this stuff. You guys need to make sure you go follow Dr. David Karli on Instagram, which is at David Karli, and Karli is Karli. We'll have this in the show notes, and then you can go check out all the work that he's doing. You can check out more about PRP, more about BMC and stuff like that at karlicenter.com. He's based in Miami right now, and a lot of people will fly from different places in the country and across the world to go get these sort of therapies so that they can help manage and reduce their symptoms and things like that. Is there any other place where people should go learn more about you and what you do?
No, those are where I'm most active is Instagram. And I was getting scolded by some of my team for not being more active on the other platforms. So we're going to work on that as well. Obviously, we're very busy, but it's important to get the word out. If people don't know about this excellent work, that's on me, right? So part of the reason to do this podcast, and thank you again for creating a forum for people like me to get this message out there. If people don't know about us, then we're not going to be as successful. So part of the message is promotional and our team and touting all of the great work that we're doing, as well as my colleagues. And we're going to continue that effort. But Karli Center and also GrayLedge Biotechnologies is the name of our biotech company, GrayLedge Tech, GrayLedgeBiotechnologies.com, or just search GrayLedge Biotechnologies, GrayLedge Technologies, and you'll be able to find that. Lots of information. As a consumer, do your homework. Not all biologics are created equal, and not all clinicians deliver it in an equal capacity. So you need to, if you're going to invest your hard-earned money in these types of therapies, do your homework, find somebody that can get the job done. But also, do they know what's in it, and can they guide it precisely into the right place? Those are the two key ones to know on the patient end.
That's great. That's great. Well, covered a lot of different topics today. David, it's been an absolute blast. I know everybody feel like they've learned a ton. You guys move your bodies. It's super important, obviously, to do the strength training to protect against stuff like this. And then, if you have some of these conditions, then maybe consider PRP or BMC, bone marrow concentrate. And make sure you follow him on Instagram at David Karli and karlicenter.com. If you know anybody who wants to learn more about this or who has joint pain and is experiencing that themselves, make sure you share this episode with them. Make sure you guys are following the podcast if you don't yet already. If you're watching on YouTube, make sure you hit that like and subscribe button down below. But David, that's all we got today, man. That was awesome. Really appreciate your time.
Thanks again, Nick. And I know you'll keep people moving and doing your part.
Amen to that. Amen to that. Thanks, man. What a valuable episode. Dr. David shared some incredible insights into managing and preventing joint pain. And the main piece of value from today's conversation was honestly almost learning about the advanced therapies like PRP and BMC that can play a crucial role in healing some serious joint issues, because these are things that I didn't really have too much knowledge on beforehand. And now I have a lot of clarity and realize how powerful they can really be. Before we wrap up, don't forget to follow the show on the Apple Podcast app and on Spotify. If you're listening there, stop right now. Go hit that follow button so you don't miss any future episodes. And if you're watching on YouTube, stop, hit that like and subscribe button down below, because you guys, look, we are going to continue to provide some of the most valuable insights with regards to health and fitness and motivation, and you guys don't want to miss any future episodes. So hit that follow and subscribe button now. Here are my 3 biggest takeaways from today's episode. Number 1, prevention is key. Like, understanding the causes of joint pain and how to prevent it can make all the difference when it comes to long-term health. Keep your bodies moving, continue to do reverse resistance training, and your body will respond. Number 2, listen to your body. Know that when you're experiencing pain, that often doesn't mean to stop. You should actually continue to work through it. And if you continue to work through it, you're going to get stronger. And oftentimes your pain will subside. If it doesn't subside, then you might want to go see somebody. And then thirdly, there's innovative therapies like PRP and BMC that are cutting edge treatments that can heal joint pain and oftentimes even reverse damage from arthritis and other conditions. These things, while they are relatively expensive, will be the bang for your buck that you need to reduce and eliminate the pain that you're experiencing, especially if you've been experiencing it for years and years. If you can do some of these things and implement a lot of the prevention strategies, and then maybe if these therapies are appropriate for you, do some of that, you're going to feel so much better, get closer to the healthiest version of yourself, and ultimately you'll continue to get closer and closer to your best you.